So today I'm going to present about one of the basic principles in trauma surgery. That is, I'm going to touch about the basic concepts of damage control surgery. So this is the overview, so I'll be running through the introduction, the stages, the indications, few examples of this initial and previous surgery that we do, and the summary. And for example, so when you get a patient who is bleeding everywhere, who's in polytrauma, who's in physiological exhaustion, blood pressure is dropping, so what would you do? Will you attend to the heart injuries? Will you attend to the bleeding? So people start to find the answer to this, even though it's very common sense. In 1983, it's Dr. Harlan Stone who came up with the concept of giving the priority to mortality over morbidity. And the name damage control surgery was given by Dr. Rotundo here in 1993. So, strict definition, what is damage control surgery? It's a strategy in trauma surgery where you meet a patient with physiological exhaustion. You give priority, you control the hemorrhage and the contamination only, because those are the immediate killers, so that you can buy time to resuscitate them and then do a definitive repair. So that's the basic concept behind it. And why the concept of damage control surgery? Because the patients are in this physiological exhaustion, they can't tolerate long surgeries, they can't tolerate definitive proper repair. So why we do that is because we can buy time to go through a proper correction, proper assessment, proper resuscitation, and in the process we use less blood products and may produce less chances of multi-organ dysfunction as well. And the stages are, stage starts when the patient is extracted from the paramedic team, that is called pre-hospital rapid transport. And when the patient arrives to the hospital, you go through the damage control surgery, and then we put the patient in the ICU where they will be stabilized in the perioperative ICU period, and then once they are stabilized, they go to the definitive repair. So when do we initiate damage control surgery? Again, it is when the patient is in physiological exhaustion, major sort of injuries, and need staged abdominal thoracic multi-organ involvement. Those are the basic indications. And the idea is you prevent the patient being put into this deadly triad of coagulopathy, acidosis, and hypothermia. Again, few indications. So pre-surgery stage, there are simple things that you can do when you meet a bleeding patient. Dr. Mahi, can you give us a few examples when you have a bleeding patient? What are a few basic things that you can do in the ambulance itself?
So there can be major vascular injuries, maybe in limbs,
yes,
as well as in abdomen, and even there can be precordial injuries.
So will you apply compression? Will you apply therapy?
In limbs, yes, of course.
Yes. Those are the simple things that we can do, but in the Western country, the concept of Godahewa virus and come up. And when the patient is arrived to the hospital, we put the patient in the theatre, we put the patient in the surgery. What are the goals of the surgery? Again, I'm emphasizing on these two words. You control hemorrhage, control contamination in your initial surgery. And then idea is again minimizing the additional physiological insult. The surgery should be done as quickly as possible, approximately 90 minutes or less we have to do it. And you identify injuries, temporize the damage, and then put the patient in the ICU to buy time. So I'll take an example of an abdominal trauma. Again, let's say patient has an abdominal trauma, patient is bleeding. There are certain things that you can do to control hemorrhage, like you identify the reduced back. You take out the organs like the spleen, and contamination control. If the bowels are damaged, you just primary repair, it is stable closure, and then you have these insults when you meet up across. You come up with these sort of patients. The bowel will be edematous, there will be a lot of bleeding. So anything that we can do to minimize this problem, minimize the post-operative ICU complications. Yes, these are few graphical representations. And yes, then you put the patient in the ICU where there will be physiological profile will be corrected, so that you buy time. Approximately it will last for about 48 to 72 hours, and then you put the patient into the definitive surgery. Again, exact timing depending on the patient's physiological profile. Usually it's about 72 hours. and may require numerous separate surgeries by separate multi-specialties. And few things about temporary abdominal closure. In the first initial abdominal surgery, you can't actually close the abdomen because there will be a second stage where you need to go and definitely repair. That's called temporary abdominal closure, and there are various modalities we can use. You know, Bogota bags, skin-only closure, the vacuum-assisted dressings, and few questions if you have any questions, I'm happy to answer. So if the person, let's say the patient's blood pressure is dropping, then there is clear externality hemorrhage, yes, you can go and apply a tourniquet, but provided it is applied safely, appropriately, the right side.
The person is not medically trained, for example,
Yes.
Is it recommended?
Yes. The problem is being the tourniquet, mal-applied tourniquet being a venous tourniquet, so that it increases the exsanguination. So you need a proper trained team, so that's when the paramedics are into the play. They have proper training in source area and all these things. So yes, that's it. We can apply, of course, to answer the question.
When there are multiple bowel injuries, would you put stone? Would you recommend putting stones?
Again, you go back to the concepts. You control hemorrhage, control contamination. As long as you clear out all the feces from the abdominal cavity, you don't have to go and even investigate this. You just put some staplers, come out. The concept is you do a quick job so that you can buy time. Go for a definitive repair.
Damage control surgery, the abdomen is, you can't close the abdomen. How would you decide like the ideal time duration for the second definitive surgery?
So again, as I mentioned in my last slide, so it depends on the patient's physiological stability, whether the patient will be able to tolerate a definitive repair. Usually, to take the evidence, it will be like 48 to 72 hours. So once the patient is a definitive surgery, you just have a look whether everything will be corrected, everything is fine. Most importantly, when can the abdomen be approximated safely? Even the slightest of chance, you put a laparoscopy, temporary abdominal closure, and then you manage it. If you can close it, you close it. Minimizing the risk of post-operative intra-abdominal compartment syndrome, which is the killer, and which is why we put the temporary abdominal closure. And to summarize again, even though it's not a novel concept, initially described for only abdominal surgery, but it is adapted over many subspecialties. And operative strategy is target to prevent immediately life-threatening problems, which is your hemorrhage and contamination, until you delay the definitive repair. These are my cut-paste reference material, and thank you so much.
So it's a very engaging presentation. Yeah. So from the audience, have you felt that he is engaged and enthusiastic? Was that feeling? Yeah. Because there were some questions that were coming enthusiastic, spontaneous from you. Why do you feel, if you felt that he was engaged, why? Engaging, why? Any reason? Okay, and the area that all are interested about. Okay, that's one thing. It's a new topic, and novel concept, interesting concept. Okay, that could be one area. But still,
Yeah, diagrams and images.
use good diagrams, yeah, and relevant diagrams are used, and to arouse enthusiasm. Yes, yeah. What about the body language? What do you think about the body language?
And the way of presentation.
Yeah. What are the positive thing that you noticed?
He highlighted main points and he used body language.
Yeah, how? What is the thing that you notice particularly? Tone is one thing, yeah, tone is good. The other thing is the way he has used the arms. Generally, it was like opening up. When you do like that, generally the audience is feeling that this person is genuine. You don't have anything to close. But if you do like that, audience will automatically feel that there's something fine. But when you're opening up, I'm not asking you to do that all the time. It has to be done in this way. And also, slightly leaning towards the audience also gives the idea of perception that you are genuinely enthusiastic and interested. You might not be able to do that in a larger lecture hall because you will be like, look like a hunchback. But with a small audience, you can do that. You can lean towards someone, then that person is generally tend towards respond and get engaged. So those are positive things. Yeah, good voice modulation. Yeah. You have selected a huge area, so not a huge area, it's our concept. But when you try to give examples, then it has become a little bit content for 3 minutes. But if you focus only on the concept itself, then you could have shortened the presentation. I could see the objectives of your presentation, so that would have improved. Yeah, the background over these are good, and the color combination they generally match with the blue and yellow. That's okay. The font of your first slide, generally, okay. The first slide, the heading. Okay, before, So what do you think? I mean, is it clear? Not very clear, no? Yeah. Better not to use ornate fonts like the Gothic and those things in the title because it's not clear. Use something like Arial. Arial is simple enough. Arial, Times New Roman is also okay, but Arial is better because what is better, Times New Roman or Arial? Arial, why is better?
It's bold.
It's more roundish, so easy on the eye. That's why I mean Sinhala letters, Tamil letters, these are easy on the eye. Okay. But Times New Roman is not really easy on the eye. But so that's something. And actually you have used the history, the next slide. Use the history and the stories, to arouse enthusiasm. That's also good. Bit over history. Sometimes people are interested. Okay. Good. Well done. Any feedback from others?
Some sides crowded.
Some are crowded, Now this also little bit crowded,
He had a very good body language to start to go along, but he was kind of rushing through the slides.
That's the problem was, once you have selected the content area is too much, then you tend to rush. That's why you have to be very selective. Give only the key message, the concept only.
In NTMC point of view, you have to be able to do any lectures. We have 13 lectures, right? So out of those, the abdominal injury lecture is like this. There are many slides. We will discuss with the EXIT, but they are not happy to remove any slides. So we'll have to do this in a different way. I think some parts of his way of presenting should absorb that lecture. So that is a difficult task. So if we get stuck with that lecture, then the whole course will be get stuck. If you can't tackle it within 30 minutes. So sometimes you might have to, and now head injury lecture has few slides. Pelvic injury lecture has few slides. So that differs according to some.